Good evening, everyone. Thank you, Roberto. Well, I want to thank you, Roberto, for this opportunity, and I want to thank everyone for staying for this lecture. I realize it's late, so I'll do my best to be fairly quick. I hope I'll be entertaining and educational for you. I enjoyed today's presentation because I learned so much about the areas of minimally invasive therapy that Italy and Europe is leading, and the US is far behind in doing these approaches. And so I want to spend a little time now, perhaps with the flip side of this, where the US has been leading the genomic field in thyroid nodules. So I wanted to share that with you for this experience. By introduction, I'm the medical director at Veracyte, and I oversee the Afirma product throughout the world. So as we heard today, the cytologically indeterminate thyroid nodules are a challenge. The Bethesda system is well recognized throughout the world and heavily used in the US, but we heard about other systems as well throughout Europe today and Great Britain, and they're all fairly similar. They have these group that are equivalent or similar to the Bethesda 3 and 4, where the risk of malignancy is not minimal, and so this has been a challenge. And this is where Veracyte focused our attention on the cytologically indeterminate thyroid nodules. But in the second half of my talk, I'll also speak about the Bethesda 5, 6, and metastatic lesions as well. So the challenge is shown here on this slide. The group of cytologically indeterminate thyroid nodules that we knew have about a 24% risk of cancer. And so how to address these and manage these was a challenge. In the US, our historical approach has been to operate on most of this cohort, which meant that 3/4 of the patients underwent a diagnostic surgery that they didn't need. They weren't relieving a compressive symptom. They were only having surgery to know if it was cancer or not. And so this created a very great burden for economic costs and complications and often hypothyroidism. And so to address this, the field wanted a rule-out test, a test with a high negative predictive value. And you can think of this negative predictive value is that amongst all benign results, how many of them are correct? So a negative predictive value, perhaps above 95%, would be acceptable to consider not operating. That would leave a residual risk of malignancy of 5%. And so Afirma addressed this with a genomic classifier, our first GEC, and now the genomic sequencing classifier, the most current version. And so you see on the right-hand side that a patient who is undergoing an FNA would have 1 or 2 needle passes collected specifically for molecular testing in case that nodule was indeterminate. And with our current product, the GSC, more than half of the nodules result benign, genomically benign, and these would typically undergo consideration for observation and not undergo surgery. And I've added, to be current with today's lectures, the possibility of a minimally invasive therapy as well, should they warrant treatment. Now, that's not written in a guideline. Those are my thinking, that these patients could be appropriate now for such a therapy. The other group that are not benign, they're genomically suspicious, they have an increased risk of cancer. These are typically referred for surgical consultation. And at surgery, you find the same amount of cancer as we used to find, but with a much smaller operative pool. And the risk of cancer of these patients would approach about 50% of cancer or NIFT-P, making better use of our surgeons' time, having them help a higher percentage of their patients undergoing the surgery. In the US, this has been cost-effective. The cost of molecular testing, somewhere around 1/3 to 1/4 the cost of surgery. So by issuing more than half of all tests as benign, payers view this as a cost-saving approach. This approach has been largely adopted. Most American guidelines have embraced this. So you see here the NCCN guideline, a large cancer network guideline addressing Bethesda 3 and Bethesda 4, and you see in both of these the option of a molecular diagnostic, and in both of these scenarios, a chance that if it's benign, that these could be observed. So this has been adopted and embraced in the US. I'll speak a little bit about the details of our genomic classifier. We couple RNA sequencing, which is a messenger RNA obtained from that biopsy, not only the sequencing of it, but then the platform to interpret, where we custom build those platforms to interpret if there's a genomic abnormality there, and couple this with machine learning to train a classifier. For example, is this medullary or not? Is this parathyroid or not? Is this benign or not? Each of these being a classifier that'll be trained, and you'll see that this is a classifier of classifiers. So combining these, we make diagnostic algorithms. We view cancer as a complicated process impacted not only from external factors, but even within the cell, the classic driver mutations we think of, but other internal factors, epigenetics of histone modification, methylation, microRNA, and an interaction with many, many peripheral genes all signaling in. And so a cornerstone of our approach to this has been to look at altered gene expression. So we really focus on gene expression to tell us what's happened within that cell in this combination of events that separates benign from malignant. So I mentioned RNA sequencing, and this is where we collect all of the messenger RNA being made in the cell, and we can sequence this for coding and non-coding mRNA transcripts. This is how we measure gene expression. Is this gene turned on? Is it turned off? To feed this into our machine learning. But in doing this, as the name implies, with RNA sequencing, we're actually sequencing all of these genes so we can detect genomic alterations as well. This gives us a chance to also do the same with the mitochondrial genome, its gene expression and alterations, and I'll talk about that as we cover the Hürthle cell cytology challenge. And we can also look at loss of heterozygosity, essentially copy number changes, where large genomic abnormalities occur, and this has been important in Hürthle neoplasia. And finally, with RNA sequencing, we use RNA as traditionally done to look at gene fusions. The currently marketed genomic sequencing classifier was validated and published in JAMA Surgery, and I'll walk through these metrics for you. It has a 91% sensitivity, meaning that if there's cancer, the cancer is called suspicious 91% of the time. Specificity is 68%, meaning of all benign nodules, they are called benign 68% of the time. And this choice to favor sensitivity over specificity allows us to create a rule-out test where you have a high negative predictive value, so that at a prevalence of 24%, the accuracy of our benign result is 96%. So every time we call it molecularly benign, it's correct 96% of the time, and we expect approximate 4% being wrong of malignancy. The positive predictive value approaches 50%, and this test is much improved in addressing Hürthle cytology compared to our prior version. I mentioned this need for a high negative predictive value, and negative and positive predictive values change according to cancer prevalence. And this slide shows that the typical Bethesda 3 to 4 risk of cancer on this slide of 11 to 29%, we anticipate this test to function with a negative predictive value in the 95 to 98% range. About a year ago, at the American Thyroid Association meeting, we reported on a consecutive series of 17,000 tests. And you can see in this data that 2/3 of the tests came back genomically benign. Of all 17,000, there was 3% that were positive for the BRAF V600E. less than 1%, here 0.6% of the 17,000 had a signature of this actually being a parathyroid gland that was biopsied. A smaller fraction were RET PTC1 or 3 fusion, and 0.2% of the cohort was actually medullary carcinoma, which we think is very important. So each of these we automatically measure and report out because, for example, the BRAF and the RET PTC have a risk of malignancy of essentially 100%. So instead of this being a 50% chance of cancer, you know these are much closer to 100%. And a parathyroid lesion is likely going to be treated much differently than a thyroid nodule. And medullary carcinoma obviously has significance, requiring typically total thyroidectomy, central neck dissection, and genomic testing to see if this is germline. Do they have a pheochromocytoma? Is this MEN2? And so we call those out. Because all of those are suspicious, they're in the third of the samples that are suspicious, you would multiply each of these numbers by 3 to know that 9% of the suspicious results were BRAF positive and 1.8% are parathyroid. Since we released this test, there have been a number of independent investigators who have now studied their own experience. All of these are published except for one is still in an abstract form. The remainder are now independent publications. And I'll walk through this slide just a little bit. Of these independent studies across the US, about 2/3 of every test that was performed came back benign by these investigators. And after undergoing testing, they chose to operate on only about 1/3 of all of the patients tested. So a dramatic reduction in surgical usage compared to prior to molecular testing. Now I'll explain these other figures with the following. Any patient who underwent surgery, their histological truth is used for these measurements. Because I told you that a suspicious patient has about a 50-50 risk of cancer, if they did not undergo surgery, I've excluded them from the slide because I don't know what to call them. For the GSC benign nodules, most of them do not undergo surgery. And so for this math, I've assumed that the unoperated cases are truly benign. What that gives you is the high end of the negative predictive value. This is the highest it would be if all of that, the assumption about the unoperated benigns is true. Sensitivity range between 91 and 100%. Negative predictive value between 96 and 100%. Specificity is probably overestimated because I've excluded the suspicious that did not go to surgery. And the positive predictive value is probably slightly overestimated, again, because some of the suspicious were not operated and the doctors guessed correctly. But here you see a positive predictive value of about 60% for cancer or NIFT-P upon final surgery. So they've gone from probably approximately 24%, now at least doubling that risk of cancer in the operated suspicious patients. Now I mentioned the challenge of Hürthle cell FNAs, and you know that Hürthle carcinomas lack the typical driver mutations that we're used to, although more has been appreciated with genomic instability, copy number changes, and other mutations. And this slide will let me walk through how we address Hürthle FNAs, but it'll also let me walk through our entire workflow. You see that our test uses actually the expression of more than 10,000 genes. We view this space as fairly complicated. When the specimen is obtained at our laboratory, we measure the quantity and quality of RNA, and only those that are suspicious move forward. And then we have classifiers that test for parathyroid, as I mentioned, medullary, BRAF V600E, and the RET PTC1 and 3 fusions. After that is over, we've removed these non-follicular tumors of medullary and parathyroid, and so we have another classifier that's built to recognize follicular cells. Does this specimen still contain follicular cells? Is this a follicular biopsy? And if it is, the sample now moves to the bottom half of this figure where we're going to generate a benign or suspicious result. Each specimen that goes to the bottom half interacts with this classifier, the Hürthle cell index, and it's going to use messenger RNA expression as well as the mitochondrial transcriptome, and it asks the question, is this a Hürthle FNA? Is this FNA loaded with Hürthle cells? If they're not, then the ensemble model, which is actually 12 classifiers, vote on this specimen and render a benign or suspicious result. If, however, this classifier says, yes, this is a Hürthle FNA, the specimen is tested by the next Hürthle neoplasm classifier. This one's going to use loss of heterozygosity and gene expression, and it asks, is this a neoplasm? Is this Hürthle specimen neoplastic? And if it is, this is also given to the ensemble model to then get a benign or a suspicious result. And the whole point of doing this is to identify specimens that are Hürthle but are not neoplastic. These have a very low risk of being malignant. They're typically Hashimoto's thyroiditis, where cytopathologist has raised the possibility that this could actually be Hürthle cell carcinoma. So those that are Hürthle but are non-neoplastic enter the ensemble model with a slightly relaxed threshold. They don't just get called benign, but it's easier for them to receive a benign result. And the endpoint is a much improved specificity amongst Hürthle specimens. So while our negative predictive value, the reliability of a benign result, was very high with our prior test of GEC, only about 20 or 24% of all tests on our previous test would get a benign result. And now with the GSC here in lighter blue, we see about 2/3 to as high as almost 90% of Hürthle specimens at these independent publications now getting a genomically benign result, dramatically reducing surgery amongst Hürthle FNAs. So that's the simple rule-out story of the genomic sequencing classifier. In addition to this, we have the expression atlas, which I'll talk about now. For specimens outside of the US, this is automatically included on whenever a GSC is ordered. This can also be ordered separately amongst Bethesda 5 or 6 nodules or in metastatic thyroid cancer deposits, lymph nodes, lung, other lesions where a biopsy can be obtained. And this is to help with additional surgical decision and therapy treatment decisions. The expression atlas is made up of 511 genes, and it looks at 761 variants and 130 fusion pairs. And what's important about this is these are measured in the expressed messenger RNA. So this is what's actually being produced within the cell. And this includes all of the abnormalities published in the TCGA of point mutations and fusions, but added to it are mutations of follicular carcinoma, medullary carcinoma, all of the RET point mutations to generate the expression atlas. So here again we see the Bethesda system and the Bethesda 3 and 4 where we run Afirma, and if it's benign, the sample is done. But if it's suspicious, outside the US, automatically we include the malignancy classifiers in expression atlas. It's also the atlas can be obtained for Bethesda 5 and 6. This is not a rule-out test. You're not trying to find it, calling it benign and no longer needing treatment. This is adding additional information on samples already deemed to be at high risk. And the last thing I'll end up talking about is its use in metastatic disease. We reported also last year at the American Thyroid Association a cohort of about 13,500 FNAs. And what you see here is the Bethesda 3 and 4 genomic sequencing classifier benign. Now I mentioned we don't report out these findings to the clinician, but we show them here in this slide. And you can see that the vast majority of those are negative for any abnormality of a variant or fusion, whereas the ones that we call suspicious have a lower rate of being negative. The most common finding in the suspicious is a RAS mutation, NRAS, H or KRAS point mutations, whereas RAS is extremely low in the samples called benign. Conversely, the most common thing we see in a genomically benign nodule is a TSH receptor point mutation, and those are very uncommon in the samples we call suspicious. Now, opening this up to the Bethesda 5 and 6 category, you see a downward trend of being negative, of finding no abnormality. And conversely, you see a rising positivity amongst BRAF V600E. And you see that the BRAF V600E is extremely common in Bethesda 6. This is the classic papillary carcinoma that cytopathologists recognize. Less common in Bethesda 5, and really uncommon in Bethesda 3 and 4. BRAF V600E mutated papillary carcinomas usually stand out to the cytopathologist, and they typically don't put many in Bethesda 3 and 4. Now, fusions are uncommon, but I find it interesting to note that the fusions generally peak at Bethesda 5 and go down into Bethesda 6. And I have a theory about that I'd be happy to share with you. You also see that RAS is most common in Bethesda 3 and 4 and becomes much less common in Bethesda 5 and 6. As I mentioned, we reported out 130 fusion pairs. These are our most common fusions reported. The most common Pax8 PPAR gamma, followed by the ETV6 NTRK3 fusion, followed by RET PTC1, RET PTC3. We're anticipating in the US probably at least 2 FDA approvals in the next year for RET fusions and point mutations. We also note that all fusions of RET, NTRK, BRAF, and ALK are always called suspicious by the classifier should they happen in Bethesda 3 and 4, and each of these are reported out to the clinician. We updated this series just earlier in the month at the American Thyroid Association, reporting on a cohort of almost 48,000 consecutive FNAs. On the right-hand side, you'll see the kinase domain of the fusion here, BRAF, RET, ALK, NTRK3, and NTRK1. And this Sankey diagram shows the kinase domain, and on the left-hand side of each figure would be the fusion partner here and here. And now the thickness of this line shows you how many BRAF fusions we have compared to RET fusions, seeing more of them here. And you'll see that in the BRAF fusions, the most common partner is SND1, whereas in RET, the most common is RET PTC1, followed by RET PTC3. For the ALK fusions, the most common partner is STERN. For NTRK3, it's ETV6, and NTRK1, TPM3 is the most common fusion. Now you can see this example for a TFG fusion partner. It formed a fusion with ALK as well as NTRK1. And similarly, you see over in this figure an ERC1 fusion with BRAF and also with RET. So a large number of fusions detected in these cohort. Now, I mentioned the TCGA publication earlier, and many of you are familiar with this. This is a publication that looked at nearly 500 papillary carcinomas, and they reported that the field they could break it into 2 categories, a BRAF-like group of mutations and RAS-like alterations. And here's their scoring system. You see the BRAF-like colored blue and the RAS-like in red. And then the alterations line up underneath this. So the BRAF V600E mutations all line up under BRAF-like. The BRAF other, like a K601 mutation, is actually RAS-like, a very different signaling. BRAF fusions or BRAF-like, RAS-like point mutations are largely RAS-like, except you'll see one here under the BRAF-like, and it's a combination of a RAS mutation with an IFAX point mutation. The RET fusions are typically BRAF-like, and you'll see the NTRK fusions kind of lined up in the middle along with the ALK fusions, and I'll come back to why I walked through all of that with you. Another group from South Korea did a very similar exercise. Here, though, they combined not only papillary carcinomas of conventional and follicular variants and encapsulated follicular variants, they also added follicular carcinomas and follicular adenomas, and using gene expression like the TCGA, divided them into buckets. But here decided there are actually 3 groups. They had the BRAF-like, the RAS-like, and a third group they called non-BRAF, non-RAS. And you can see the abnormalities that belong to each of these groups. The non-BRAF, non-RAS was IFAX, P10, Dicer1, Pax8, PPAR gamma, Pax8, GLIS3, and you can see the list. And what's interesting amongst these two publications is if you pool them together, you see a trend as reported in this abstract and manuscript under development that shows the BRAF-like having a higher risk for whatever you're going to measure versus RAS being lower and the non-BRAF, non-RAS. So if you look at lymph node metastases, they were highest in BRAF-like, lower in RAS, and actually 0 in the non-BRAF, non-RAS. N1B lymph nodes, that same pattern. And then if you start combining them with gross extrathyroidal extension, you see that same pattern with vascular invasion and multifocality. So the genomic signatures tell a story about the risks of these tumors. Here's an example of a patient report that we use to reflect this. This is an updated patient report that'll start to go into usage this next week. It's an example of a Bethesda 3 cytopathology that was determined to be GSC suspicious. It's negative for medullary carcinoma or parathyroid. It's negative for the BRAF V600E and RET PTC fusions, but it's positive for a BRAF K601E mutation. We provide these details here and then summarize it down below, saying this is a Bethesda 3 GSC suspicious nodule with a BRAF K601 point mutation. This has a risk of cancer of approximately 50%, and this alteration is associated with follicular neoplasms like a follicular adenoma, NIFT-P, follicular variant of papillary carcinoma, follicular carcinoma, and has a RAS-like profile. This has rates of lymph node metastases and extrathyroidal extension that are lower than a BRAF V600E-like mutation, but higher than the non-BRAF, non-RAS neoplasm. Clinical correlation and surgical resection should be considered. So this added information allows the clinician to think about not only the risk of cancer, but these other factors. Now, this is just added information, and the clinician still needs to use their judgment. Had this been a BRAF V600E, it would have said it has a higher risk of lymph node metastases and extrathyroidal extension. It doesn't mean that they have to necessarily get more aggressive care, but it allows the physician to go back, look at the ultrasound, look at the lymph nodes, and decide what they're going to do. They may argue, I see no extrathyroidal extension, I see no suspicious lymph nodes, I'm still comfortable with doing a hemithyroidectomy. But it gives them more information to think about those risks. Now, I told you I would also talk about metastatic therapy, and I know the hour is late, but perhaps you might recognize my patient in this figure. This would be from the popular HBO Game of Thrones series. Here's our hypothetical patient, an older man, who presented to a local hospital with a neck mass. He had a neck CT that showed a large mass in the neck that actually on PET scan is FDG positive. He's got a lateral neck lymph node that's positive. He's actually got PET positive mediastinal disease and small lung nodules that are PET negative, but maybe too small to know right now what they are. When his physicians met him, they did a biopsy of that large 3 centimeter neck lymph node, confirming it was papillary carcinoma, but also molecularly testing it for the, with the expression atlas. And this turned out to be positive with an ETV6 NTRK3 fusion. Are people in the audience familiar with NTRK fusions? Do they ring a bell to some of you? So this has become important, especially in the US, because about a year ago, we saw the first FDA approval for a specific NTRK inhibitor. And this is somewhat of a new era of oncology for us because this drug is not approved specifically for one carcinoma. It's approved for any solid carcinoma that has an NTRK fusion. So now we're treating according to molecular information, not according to the cancer type. This is referred to as tissue agnostic. So if you're an adult or even a pediatric patient with a solid tumor, if you carry an NTRK fusion, you could be a candidate for this drug. And it's fairly specific to the NTRK fusion, which means it hits fewer other targets. So typically side effects are less, and these drugs are better tolerated than the multi-kinase inhibitors that we were used to of sorafenib, lenvatinib, et cetera. And just a few months ago, a second NTRK inhibitor was improved. So now in the US and perhaps at other places in Europe, you now have these very selective therapies that this patient would be a candidate to receive should they have progressive metastatic disease unresponsive to other therapies. This is a report that would come if this were a thyroid nodule that I pulled here, but this has an NTRK, a positive result. Had this been a thyroid nodule, the risk of malignancy is very high. This is associated with papillary carcinoma, and yes, there are NTRK fusion-specific therapies available to alert the physician that there may be a treatment should this patient need it. So in summary, after starting in just cytologically indeterminate nodules, you'll see molecular diagnostics in the US have now moved into Bethesda 5 and 6 and metastatic arena, all through an FNA. For thyroid nodules, as shown in this figure, this is coupled with doing a thyroid FNA and getting cytopathology, but when the biopsy is done, a sample is collected for the molecular testing into a dedicated tube. The Bethesda 3 and 4 nodules can benefit from the rule-out testing, the genomic sequencing classifier, and if it's benign, typically these patients would be considered for observation and perhaps may benefit from a minimally invasive therapy. Those that are suspicious then have the expression atlas obtained, which could also be obtained on the Bethesda 5 and 6. And this is a goal to personalized treatment, giving you information about the risk of cancer, what kind of neoplasm this is going to be, a papillary carcinoma, a follicular neoplasm, medullary, parathyroid, but also prognostics as we start to think about BRAF-like and RAS-like tumors and their associated risks. Is there a systemic targeted therapy available, and also potential heritable syndromes like PTEN and Dicer and MEN2 to point all of these out on these patients. On the right-hand panel, you see again those advanced patients with thyroid cancer where you're looking for a targeted therapy, sticking a needle in the metastatic site and collecting a molecular sample. When it's proven to be thyroid cancer metastatic to your target, the atlas can hopefully identify targetable treatments that the patient could benefit from. And unfortunately, if they escape a few years down the road, they could be rebiopsy and hopefully identify another target. So I hope that this information has been interesting. It's where the US is really headed in thyroid diagnostics, molecular profiling, and I appreciate your attention and the opportunity to speak with you tonight. Thank you.